It's a great pleasure to introduce my ex-colleague from Leeds, Dr. Emma Rowbotham, to talk to us today on dual energy CT. This was something we were just really starting to get going when I left Leeds, and Emma was very much the key worker in that area to drive it forward. So I'm delighted that to see it has developed so well in Leeds. Emma was a Leeds trainee. I think I probably taught her as a first year many years ago, and subsequently became, I think, certainly if not the only, but the first of our own trainees we ever appointed to our Leeds Fellowship in MSK Radiology, which, as many of you know, is one of the strong MSK fellowships in the country. We normally push people out of the department to go and work elsewhere, but we couldn't let Emma go, so she came and worked as our fellow, and subsequently did a couple of years working in Bath at the musculoskeletal, as a musculoskeletal radiologist there. And then we were lucky enough, when I was in Leeds, to appoint her to Leeds as a consultant. I then discovered what it's really like to work with her, which is I moved to Cambridge. No, that's not true. And plus the fact that we've been walking around Addenbrooke's today, and Emma's been going, this takes me back to being a house officer, because she was also a house officer here at Addenbrooke's, having done her clinical training at Cambridge. So I'll hand over to Emma to tell us all about dual energy CT.
Thank you very much, Andrew, and thank you, Professor Gilbert, for your introduction as well. It's a pleasure to be here. Thank you for inviting me. I have actually been in this room many times before. As Andrew was taking us to this room, I didn't know where I was going, and I thought I have been in here before. We used to get rapped over the knuckles with a ruler by Professor Dixon in this room regularly. So I have very fond memories of Addenbrooke's and also Professor Dixon, and hopefully learned quite a lot of what I know today in this department. So I'm going to talk about today dual energy CT in MSK radiology. So I apologise in advance to those of you who are not particularly involved in MSK radiology. I'm sure you use this technique in other specialties and will know far more about that than I do. And I'm not going to branch out of MSK today, but hopefully I can talk about some of the things that will be interesting and some of the trauma that some of you may report, even if not specifically doing other bits of MSK. So I'm going to talk about predominantly the system that we use in Leeds, which is a GE system, which is termed gemstone spectral imaging. So that's what I'll refer to quite a lot. That's just our GE system that we use in Leeds. So of course, dual energy CT is by no means a new phenomenon. It's been around for really quite some time. And as I've said, I'm sure it's used in lots of other specialties within this department. And certainly there's lots of literature around there in various other regions. What it does is just enhance the diagnostic capability of CT. So I feel it's really helping. I think the title of this talk had been put out as, is it a help or a hindrance? I'm going to very much put forward a positive view of dual energy CT, and I think it really enhances the diagnostic capability. In MSK in particular, we're looking at really these three things. We're looking at metal artifact reduction, we're looking at detection of gout or uric acid particularly, and we're looking at the detection of bone marrow edema. And as I'm sure you will know, and if there's any physicists in the audience, don't worry, I'm not going to try and talk too much physics here, because that's again slightly out of my depth. But there are two different ways of performing dual energy CT. So we either have a dual source, where there are these two X-ray tubes, two detector plates using the different energy levels, or you can use rapid kilovoltage switching, which is this single tube within a large gantry, and it oscillates between those energy levels. So they're doing the same thing, but by different means. You've got those two quite different means. And why has it come about? Why has it come about particularly in MSK radiology? And I think really the main reason that we see is that 2D CT has less capability of detecting important things that we want to see. We've always said that bone marrow edema can be detected on MRI and not on anything else, and that becomes a bit of a drawback when we're looking at CT. So if we can use CT to look at bone marrow edema, then we've got a perfect modality for imaging a lot of MSK work. Gout, I think it's fair to say that dual energy CT in gout has become fairly well established. It may be something you do already. And I think, again, it just adds something that we haven't really been able to get elsewhere. A lot of imaging features on other modalities are non-specific. So it may be that these patients don't get a definite diagnosis, but on dual energy CT, we've got that definite diagnosis, which the clinicians now have a lot of faith in and we can trust. There is no significant dose penalty. The reps will tell you there's definitely no dose significant penalty, and we've done our own audits in Leeds looking at various different body areas, and I can quite confidently say there is in general no significant dose penalty. Clearly some patients will have a slightly higher dose than others, but in general when we add the dual energy we're not seeing a higher dose. So in my view, no reason not really to use this technique as often as you think it's going to be useful. So as I've said, the product that we use is a GE product specifically, and they term that gemstone spectral imaging. It uses the rapid kilovoltage switching as opposed to the other method, and that allows dual energy sampling almost simultaneously to generate material density data that then can be used for the separation of materials and derivation of monochromatic spectral images. So the coloured images and the gout images, which I'll show you just shortly, to look at various different diagnoses. And the fast kilovoltage switching alternates between two energies, and namely in this system between 80 and 140 kVp. The dose just alternates between them, and therefore the exposure can be thought of as approximately the average of the two energies and not the sum of those two energies. And as I said, the dose exposure is very similar in terms of dose to just standard CT. So the gemstone spectral imaging uses this single source detector, 128 slices per rotation, and we can identify either iodine, which clearly is not really used in MSK radiology, calcium and water, and those are kind of factors of those. Single source architecture can generate these material composition images over that full 50 centimetre view, so that's one of the advantages of using this technique. I'm going to be entirely honest, this is a GE slide, so this is just selling all the good points about this particular, I'm not going to go through this, but I think it is a good system, and they do say that it's faster, so it's a very fast technique, doesn't actually take any more time than a standard CT. They used to have to boot up the old Siemens scanner to get it going, don't have to do that anymore, so there isn't any time penalty particularly on that either. So moving on then, I'm going to start talking about these two main areas. So first of all, I'll talk about dual energy in detection of bone marrow edema, and then later on I'll talk about gout imaging. So as I've said, it's long been cited as an advantage of MRI over CT, this detection of bone marrow edema. And in MSK imaging, bone marrow edema is actually really important. We use it as a positive sign in various different conditions. So in bone marrow edema, I'm predominantly going to talk about fracture and trauma, but as I get to some of the later on cases, we'll also be talking about bone marrow edema in, for example, sacroiliitis, so not just fracture. This virtual non-calcium technique, which is the techniques that are widely employed, allows the removal of trabecular bone. So it's just part of the post-processing, allows that removal of the trabecular bone from the voxels, and then you can assess what's in a particular area much more easily. This is a standard, looks a little bit out of focus from here, but is a standard calcium water map, and it may be something that you already produce. Clearly, if you just look at those, it looks like we're going backwards. That doesn't look like a great CT image, and certainly not from where I'm standing. But this is what we've come to find quite useful as a calcium water map. And as I'm looking at now, I can see two differences between that left side and the right side, which may be thought of as quite subtle. But if you have a look at this region of the left, I'm just indicating with the pointer there on the left greater trochanter, you can see that it's a little bit different to the right-hand side. And these are the unprocessed, these are the images that come through onto our PACS system as a calcium water map. And in fact, some of my colleagues use these to read solely without post-processing anything. I'm not going to advocate that, but hopefully you can start to see some differences, which we'll talk through in a moment. So you can have the calcium water map, or you can colour everything. Now, I really like to colour everything, and I think it's really personal depending on how you want to do this. But even if we just look at a simple colour image, this is a patient who had early osteoarthritis of the glenohumeral joint, and we've coloured green as edema, and there is some edema starting to come into the humeral head articular surface and a little bit into the glenoid as well. So as soon as we colour things, I think it becomes more obvious and becomes a little bit more definite what we're looking at. So for quite a long time, it's been accepted that we can use dual energy CT to detect bone marrow edema. But looking at these, the early papers, sort of 2010 and onwards, they just showed that we could use dual energy CT to reliably detect bone marrow edema. But at that stage, there wasn't really good evidence that this had been compared with MRI and that it could compete with MRI.
Sorry,
Or in fact,
explaining that image to me. Sorry, where's the edema? The purple's edema, is it? Or
no, green. So I'll go on to in a moment. This was just a brief illustrative image, but I've
purple's normal there.
Purple's normal there.
Okay.
Yeah. And this, which I'll talk about a little bit later, so you might say, well, there's green here in the ribs and there's green here in the scapula, but where you've got cortical bone against cortical bone, it's one of the areas that we can't use it reliably. There's not enough marrow within that region to reliably detect bone marrow edema. So ribs, for example, it's really poor in ribs because there's not enough marrow within that region.
So you're seeing a bit of edema just under the on the humeral joint surface.
Correct.
Yeah.
So looking at these papers, some of the early papers, these are some of the ones that said we could use dual energy CT. The first one from 2012 looked at ankle trauma and showed that dual energy CT can detect edema with high sensitivity. There was low specificity at that point. And then another paper from 2014 looking at hip fractures, again, really high sensitivity for detecting bone marrow edema, but we didn't really have the proof that it was as good as or better. So why would we use it when MRI was widely available? I've then tried to summarize some of the more recent papers. So I think before I show you any images, just to say there is now emerging evidence that it's becoming as good, certainly where MRI is not available or when there's any contraindications, which I know are becoming fewer, but where we don't use MRI, dual energy CT is becoming really up there in terms of sensitivity and specificity. So these are just some of the most common areas that have been studied. Scaphoid, first of all, this was from the Oxford group. They only had 20 patients, which is clearly something of a drawback, but they showed that the dual energy CT was equal in detection of bone marrow edema to MRI. So that's something we've started to look at in Leeds. We definitely need bigger studies there. That's one of the biggest studies in scaphoid imaging. Pelvis, I would say, so pelvic trauma, pelvic fractures is one of the most widely published areas in this topic, and there's plenty of evidence out there. This is just one such study. I think whenever they say 100% sensitive and specific, you've got to be slightly wary, but anyway, extremely high sensitivity to bone marrow edema, and particularly within the proximal femur. Pubic rami less so because, as I mentioned, there's more cortical bone there compared with the marrow, so it's much better in places where there's lots of marrow. Vertebral body fractures, again, this is something that we're trying to look at more and more. It's not really there yet in the spine, and much of the literature will say that this is very reader dependent at the moment in the spine, not as sensitive or specific. And so definitely needs more work. And then there's some peripheral trauma. So there's plenty of evidence in peripheral trauma that that we can detect bone marrow edema, and then we can improve reader confidence, which can be important. And I think particularly in Leeds, where we're looking at our trainees doing a lot of on-calls, improving the reader confidence is being thought to be fairly important. And then SI joints, I'm going to talk about that in more detail a little bit later on, but again, it's an area where there are some problems immediately adjacent to the cortex, but we have shown that we can use this technique to detect sacroiliitis and bone marrow edema with relatively high specificity and sensitivity. So let's move on to show you the odd case and to show you what I would actually do when using this technique. So we know that plain films can be normal in inverted commas in between 3 and 10% of femoral fractures. So there's definitely a rate of occult fracture or fractures that are missed because they're extremely difficult to see on plain film imaging. CT will definitely improve the accuracy, and I think it's fair to say in these we do quite a lot of CT for pelvic fractures and pelvic trauma, and definitely improves our pickup rate. But it is an area where we now scan all of our pelvic trauma patients with dual energy because we think it helps, and it definitely helps with the confidence, and perhaps some of these patients don't go on to have MRI. And the literature says we can improve that specificity up to closer to 95% or so. So hopefully you've been having a look at that plain film as I've been talking, and I think probably most people would report that as normal, and it was reported as normal. Sorry, it's backwards and forward. So this patient had a CT, and there is a fracture on this CT, which I'll just find my mouse, is over here on the left greater trochanter. So there's a cortical breach just here, and clearly you've only got one image, and I'm sure with the full data set, most people would pick up that fracture. But I think it's fair to say it is fairly subtle. And I'm going to use this case to illustrate how we can use bone marrow edema technology to have a look at that in a little bit more detail. So this is the standard CT image on a soft tissue window. This is the calcium water map. And it's exactly the same image that I showed you on one of the early slides, but this is the calcium water map. So these get sent through to PACS. You don't have to do anything to get these. They just go through as the radiographer does the study. What we can do is, so we process these on a separate server. So if I would say there is one drawback of this technique, it's that you have to go onto a slightly separate server still on the desktop, but I have to log in. And we've set up the protocol to colour in bone edema. So we are colouring voxels relative to how much water is in those voxels in milligrams per cubic centimetre. Now you can select any preset and you can colour anything the way that you want to colour it. So none of these are standard. They're all just because that's the way that I like to colour them. And hopefully you can appreciate a difference within the proximal femur bilaterally. So on the patient's left hip, it's very bright yellow compared with the right hip, which is much bluer. And the scale would obviously be on the desktop of the server. And you can see there's a difference within those two regions. But we can take it a little bit further. And this is what I like about our particular system that we've got, is that we can say for sure what we think is going on there. So one of the things you can do, they're not quite so basic as these dots, but I've just done that for purposes of making it a little bit more obvious. It's slightly more high tech than that, but you can pick regions of interest, and you have to do that manually. So you can pick a region of interest that you think has been coloured perhaps on the data that you've already seen or on your colour map already. And then we can plot those in terms of, as I said, milligrams per cubic centimetre, what's going on within that region. I'm not saying that we would do this for every case, because clearly this is quite time consuming, but I think just to get confidence and to show that what we are looking at actually means something, I think this is quite useful. So if we look on the left hip, I've put a region of interest in red there, and obviously corresponding that to the graph, and we can see that there's much higher water content within that region compared with the blue normal hip on that side. It doesn't take long to do, and I quite like this, and certainly it's been helpful when setting up newer protocols when we know that there's fractures or we know things that it can really help our confidence.
I can't see any difference between those two. Is that me? So what on the graphs, what's the difference?
The amount of water
is in red on one side.
So the left hip has more water milligrams per cubic centimetre.
I can see that on the image, yeah.
So it's the higher percentage on the
area under that graph is more on the right, is it?
No, the percent.
It's 900s there and 1000s on the reds.
Yeah.
Yeah, there's more water.
It's the water scale on the bottom. It goes from 900 up to 1000,
okay.
And all the reds are over 1000.
Thanks, Sam.
Thanks.
No, not at all. I'm sorry if I made it clear. Yeah, thanks, Emma.
Yeah.
Yeah, it's the scale. So we just don't have as much water in all the voxels on the blue side.
Yeah, right.
We've got much more water on the voxels on that side. And then I think in using that in combination with the colour map is what I like to do, and then you can be fairly sure. And of course, this is quite an extensive process to go through for plain pelvic CT, but in some of these cases where the patient can't undergo MRI and the surgeon really wants to know, I think we can be a bit more definite and give them some more definite evidence as to whether they need to take this further or not, and hopefully that's clear to you that we can see those differences on there. We should also be able to prove that particular appearances are chronic rather than acute. So on the previous case, I've shown that there's more water in one particular side. We should be able to say there's not more water. So this is a case looking at inferior pubic ramus. Clearly there's remodeling on the right hand side, and we want to see, is that acute or is that chronic? And clearly that can be applied to anywhere, but this is just a particular case that we've post-processed. So we can put the two different regions of interest again on this side, and I just blew up that image. This is what we'd actually look at on the desktop, but that first image was just to show that remodeling in a little bit more detail. But hopefully now you can see this overlap of those two areas, the pale blue and the darker blue. There is no significant difference in water content within those regions. So this is a chronic fracture. There is no bone edema within that region. They're very similar, and it's a chronic fracture. And again, we can apply that to anywhere. And again, within the setup, you can just show the graph, and then you can look and you can move your regions of interest around if you want to. So it's quite quick just to move to different places. As I've mentioned, vertebral fractures are a little bit more controversial, and I don't think at the moment we can confidently say that this is what we're doing regularly, and that is of a huge amount of help. But again, this is an image just to show how we can be sure that there is bone edema within a region. I think the actual clinical application is more relevant to saying whether it's an acute or chronic fracture. So particularly in probably osteoporotic fractures, is it acute or is it chronic? But again, we can put a region of interest, we can plot where the water content is, and in this case, we've got an MR to show that there is bone edema within that L4 vertebral body, not in the L3 vertebral body. And then if you plot those regions of interest, you can see there's more water within the L4. Some of the studies show, again, relatively small numbers. So this is a little bit bigger, 76 patients. And they looked at the comparison between edematous and collapsed non-edematous vertebrae, and did show that the diagnostic performance was close to CT. This is one of the only papers that really shows that. I would say at the moment, the detection is not that good, and partly because, as you can see on this image, and as I've mentioned before, sclerotic bone takes a bit of a precedent here and can skew the results somewhat. I think it can be helpful though, and again, this may be something that we do in Leeds more than anywhere else, but if you have a patient with thoracic back pain, and I find a negative result, so this was a normal dual energy CT going on at the same time as the standard CT, and there's nothing occult to pick out there. So hopefully if we had an osteoid osteoma or something else causing thoracic back pain, we would be able to see if there was something lighting up there on the dual energy component, which there isn't. In peripheral trauma, there is, again, quite a lot of evidence to suggest that this is sensitive, it's specific, and can help. Now, you may argue that in most of these cases, you can see the fracture really easily, and perhaps picking cases for a talk makes that slight bias by, showing nice examples. But if we look at a lot of cases, we can see that, hopefully you can see the fracture here through the tibia, and that really nicely lights up again in the colour that we've designated, and that's just arbitrary. The calcium water map is probably quite useful in this case, and again, the standard CT is probably all you actually needed. But just to extrapolate that, I think it can be helpful where there's minimally displaced or non-displaced fractures to show that there is bone edema there. This is a recent case that we're just starting to use this technique in scaphoid fractures. And as we can see, there is non-union of a scaphoid fracture and there's sclerosis of the proximal pole. But if we overlay a bone marrow edema protocol onto that, we can see that there is relatively little water within the proximal pole. So giving us somewhere in sort of the information that you would get from an MRI in terms of deciding whether there's avascular necrosis or what's going on in this proximal pole. We don't yet do this routinely, and I think at the moment the evidence suggests that we shouldn't be doing it routinely, but in cases that we've got like this, we're just adding it in to see what information we can get at the moment, and I think it is something that will come a little bit more over the next few years. Inflammatory arthritis is one of my particular research interests, and this is an area that I think it can be useful. And according to our rheumatologists, there's quite a few patients who can't undergo MRI in their clinics, compared to the general population. So perhaps that's an opening there. A paper in European Radiology a couple of years ago was a really good paper to start all this off. And all patients had sacroiliitis, they all had dual energy CT, they all had 3T MRI, and they had a sensitivity of 81%, but a specificity of 91. So if your patient can't undergo MRI, then that's much better than anything else we've currently got. As I've mentioned, this virtual non-calcium technique is the way that we do this. Caution is needed with conversion of red marrow. That can give some artifacts, or sclerosis near the articular surfaces. And obviously with very subtle bone marrow edema, that can be something of a problem. This is the sorts of images you can get from the SI joints. And this is a patient with sacroiliitis and bone marrow edema, particularly affecting the left SI joint, that iliac side. The paper that I've just quoted here had, again, 47 patients, so no one's getting huge numbers here. And they had a mixture of symptomatic patients with axial spondyloarthritis and 6 patients with no symptoms as their control group. And they're getting much higher sensitivity and specificity. And I think this gives us reason to really push forward with this and try and help. The one caveat in this particular group is that these results are worse in patients with low-grade bone edema. So I hope you'd agree that for a sacroiliitis, that's a reasonably extensive bone marrow edema. So that's fine. And we can see that there's, this is now, we've got scale on this side, so a higher amount of water content on this left-hand side corresponding to the bone marrow edema, but on the right-hand side that's normal, we've got a much lower water content. But in cases where we're not seeing very florid bone marrow edema, it can be a little bit more difficult. As with any technique, we've got to worry about artifacts and pitfalls, unfortunately, and cortical lesions are problematic. So thickened cortex or even just cortex near cortex becomes problematic. And we do get false negative results in sclerotic bone. So this is a case of Paget's, which I'll show you the dual energy in a moment, and false positives in physiological red marrow, which again we have to be cautious of. So this is sorry, backwards again. This is a case of Paget's, and again, because we do this on every case, we did a dual energy CT in this particular patient, and as you can see, it's just pretty useless on this right hip. On the proximal femur, we're just getting artifact there. Wouldn't be any use at all in this particular case. So we have to be careful of some of these regions. So just going to talk about gout then for another 10-15 minutes or so. And again, apologies if this is something you already do. It might be something that's already well established.
Not, so carry on.
But we see a lot of patients with gout in our practice. Obviously with the classic symptoms of severe joint pain, first MTP joint, but also lots of other joints and often joints that you're not going to particularly expect. Hot, swollen, red and painful joints, but usually or often with no previous history of gout. And it's the most common inflammatory arthritis with male preponderance. And as I mentioned, we do have good MR imaging. We do have some good ultrasound findings as well, but none of them are definitely specific. And hopefully I'm going to show you a couple of cases that will show that. But I think if we can add dual energy in there, then we can be a lot more definite. So what do we see in gout? Well, we see this aggregation of crystals, but as I've mentioned, with no specific imaging features. The ultrasound effusions can be of help, but are not of definite diagnostic value. And changes related to the cartilage and the synovium can often be more helpful, but again, not particularly specific. And you may be familiar with some of these signs, so icing on the cake sign and that sort of thing, but we can also see that in other conditions. I think dual energy in this particular forum is really helpful just where the clinical picture is unclear. So some of the examples I'll show you are clearly of patients with florid gout that we've had a reason to image, but our clinicians use this quite a lot in patients who they just don't have a definite answer. It's quick, it's easy, it's well tolerated, and you can either perform a multiple joint scan, as in this case where we've done both hands, or a single targeted joint, whichever is easier, or whatever you want to do for that particular patient. We often do both hands or both feet or just the symptomatic joint. Similar images to how I'd set up the bone edema protocol. So these are again from the post-processing software, and we the way that it works, you have to pick pairings. So I picked calcium uric acid. Hopefully on this top, that's a volume rendered image showing a huge amount of tophus around the first MTP joint. And you could argue that in this case, we really didn't need dual energy to get the diagnosis. And if you look at the top right-hand portal, you can see quite clearly this huge soft tissue tophus, which is unlikely probably in this location to have been anything else. I think the 3D reconstructions are really helpful. Our clinicians like those. They like those in the rheumatology meeting because they feel like they're getting a good assessment of the volume of disease and what's happening there. But we can focus in more on these regions of interest if there's a particular area that you want to look at a little bit more, just as we did with the bone marrow edema. This is a case that came through our sarcoma MDT as a soft tissue mass anterior to the knee. No history of gout, otherwise fit, relatively young patient, so no reason particularly to suspect that it was gout. You can see as we go through the images, there is some underlying cortical destruction to the patella, and that CT probably shows that quite nicely as well. So perhaps it should have been thought of at that point, but equally it was thought it could be potentially a soft tissue malignancy as well. So it came to the sarcoma MDT, but before it was biopsied, we just decided to, somebody thought, you know, let's have a go, see if it's gout. Similar calcium water maps are produced in this area. I don't think they're as helpful at all in gout. I think in the bone marrow edema, I'm starting to get comfortable with looking at those differences on the 2D imaging, but I think in the situation of gout, then you probably really do need to employ some colour mapping. And this is the sort of thing that we're going to produce. So top left is my volume render image, and not only has this patient got a huge amount of uric acid deposition superficial to the patella, but also you can see it all around the knee joint. All of that stuff that is kind of on top of the bone is uric acid. If we look at the bottom left, then we've coloured gout in green, and in fact that soft tissue mass within the prepatellar extension of the extensor mechanism is really lighting up, but equally so is the proximal and distal patellar tendon, and there are bits and pieces within the joint as well. So we were pretty confident, but because this case had gone through the sarcoma MDT, it was actually biopsied as well, and it was gout. So gave us a nice full circle of proving that that's what it was. I like to just colour them again. I just feel it just really brings out what we're looking at. So this was the disease load in this particular patient, and hopefully you'll agree that that's fairly convincing of being extensive urate deposition. Because I like a graph, you can also do a similar thing with these. And as I said right back at the beginning, I'm not going to pretend I do this for all cases, but I just think it's helpful. And we've had to go through a process with our clinicians of them understanding and believing this technique. And I think this really helps everyone to get on board with the fact that it is really helpful. So what I've done in this case is label, it's not actually projecting very well, sorry, it's probably a little bit tiny on there, but a red, a yellow and a green area within the joint. And then just for comparison, I've put a blue region of interest over the proximal tibia here, just to show that's nowhere near, and you wouldn't expect to have any uric acid within that particular region. And that's got far less. So the scale on this one is uric acid milligrams per centimetre cubed on the bottom axis. And hopefully you can see that in that blue region, there really is not very much compared to the joint, just to prove that we're looking at that within the joint, and just to blow that up, just to show that graph again. And then a second case, quite similar, but just in a slightly different location. So again, we've got a soft tissue mass. Nobody really knew what this was. And again, if we look at the T1 coronal over here on the left, there is some early erosive change. So with hindsight, yes, that's gout, but at the time, I think there was concern that it was a more aggressive process. But the dual energy, not as impressive in this case, but the dual energy, if I pull out those images, has got the uric acid deposition here. I'm not going to bore you with a graph again for this particular case. Probably had enough of my graphs in those cases. This is a case where we've just done both feet to have a look. The plain film was reported as normal, but I think with hindsight, there probably was some erosive change across that first MTP joint, and purple within the toes has been designated here as uric acid deposition. So they did have bilateral deposits, and with hindsight, quite a high urate within the blood. Artifacts, again, not useful where there's metal around, you get this distorted image. It's difficult to accurately define any regions of interest when we've got metal around, and may give some false positive results. A fairly useless looking volume render image down the bottom, but also fairly large distortion. There are well-known artifacts, and much with any imaging in radiology, once you know where the artifacts are, it's easy to discount them. The nail beds or the nails themselves and the skin are very common areas of artifacts. Colouring of the pixels, colouring of single pixels, so single pixel, again, we usually would completely discount that as just being a reason of artifact. Beam hardening is another one, and calcified vessels will often come up as looking exactly the same as an area of uric acid. Very good paper looking at these artifacts done by one of our colleagues from Leeds a few years ago now, and you can see those areas that are coming up, the skin in this example, and on the volume render as well. So we know to discount that as being genuine areas of uric acid deposition. So that's all the cases that I wanted to show you. Just in summary, really, I think this technique can improve reader confidence for fracture detection and may reduce the need for MRI. And I think at the moment, that's probably the most definite conclusion that we can draw. And that patients with contraindications will definitely benefit. I think the more the research comes out, we can look at dual energy CT as a viable alternative in patients with sacroiliitis as well as trauma. But again, I think a little bit more work needs to be done in this area, mainly because it's not quite so good at picking up very low levels, and that's actually the cases that we're most interested in. I know it's already a useful, well-utilised tool in cases of suspected gout, and I think the evidence is definitely there to use that. The clinicians believe in it. Most MSK radiologists believe in it, and I think it's a really useful tool in that setting. Thanks very much for listening, and hopefully I've shown you some cases of what we would use the dual energy CT for. Thank you very much.